Good afternoon, dear colleagues. You are connected through my channel with San Raffaele Hospital in Milan. And we start today with the first roundtable concerning how to create and implement a program of laparoscopic liver resections. The full program is divided in 3 round tables. So this is the first one, then we will have a second and the third one, based on the different level of complexity of laparoscopic liver surgery, because our goal is to give all colleagues the opportunity either to start or to implement a personal program of laparoscopic liver resections. Today, we have the opportunity to have a very distinguished colleague discussing about the first point, that is how to create a laparoscopic liver program and how to deal with the low complexity procedures. So we have Dr. Åsmund Fredland from Oslo. Hi, Åsmund. I hope you see us. And you know, Oslo is probably one of the most important schools of laparoscopic liver surgery in all the world, but for sure in the Western countries. And so it's for us a great pleasure that we may have his comments, his contribution, and his videos about laparoscopic liver resection. Then we have another great friend, Alessandro Ferrero from Torino. Hi, Alessandro. And Alessandro is leading a very important program of laparoscopic liver resection in Italy. And I can say that he is one of the most skilled pioneers of the use of laparoscopic ultrasound, which is one of probably the most important instrument to deal with laparoscopic resection. So thanks to his expertise, we will have the opportunity to know how to use this critical tool in laparoscopic liver resection. And finally, we have Dr. Besseling from Amsterdam, which is probably late because I'm sure Dr. Besseling thinks that all Italians are late, so he wants to be online with our attitude, but I'm sure he will connect later on. So the program is including some presentations, so I will not spend too much time to introduce my colleagues, and then a second part that would include videos about low complexity liver resection, so that we hope you will be encouraged and eager to participate to the next roundtables to learn how to do intermediate and high complexity procedures. So I will start to introduce the argument of today, describing you basically how to define the complexity of a liver resection. So I think we can start with the first part of the webinar. So if okay, so the first topic is obviously how to define the complexity of a liver resection. And I think it's very interesting that differently from open liver resection, where actually nobody studied deeply the issue of the complexity. For laparoscopic liver resection, we have now really the possibility to understand how is complex a liver resection that we are planning to do. And obviously, if this liver resection is critical for us, or we have the good expertise to deal with it. Here you can see how laparoscopic liver resections are part presently of liver surgery. In the last 10 years, well, almost 15 years, we have already basically 3 international meetings concerning this type of surgery, with the first international position paper on laparoscopic liver surgery back in Louisville, 2008. Then in 2014, the second international conference on laparoscopic liver surgery in Morioka, that was basically defined and run by Professor Wakabayashi. And finally, in 2017, we have also a third conference on laparoscopic liver resection. So this means that there is a lot of attention about this issue, and that we can count on these papers to apply laparoscopic liver resection in our daily activity. And indeed, in many liver centers, laparoscopic resection are part of the common activity. Here is, for example, the experience here in San Raffaele Hospital. We started with laparoscopic liver resection in 2004, and you can see the green line is the line of laparoscopic liver resection, the blue line the total number of resection per year, and the red line the line of open liver resection. And you can see how after 2014, that is basically the same year of the Morioka consensus conference, the number of laparoscopic liver resection increased over the year, crossing the line of open liver resection in 2016, so that now we do almost a 2/3 of resection by laparoscopy. Last year we did 240 liver resection by laparoscopy, and a little bit less than 100 resection by open. And what is important is that at the present time, by laparoscopy, we are actually able to perform almost all kind of resection. So that's why it's really important to pay attention to the complexity, because it's pretty clear that the more we increase the complexity of a resection, the more probably we take the patient to a higher risk. So it's absolutely crucial for any surgeon to deal with laparoscopic resection, understanding the complexity of each operation. You can see here we may have a low complexity area where we can put minor resection in laparoscopic segments. We can put the left lateral sectionectomy. Then we may have an intermediate area where we can put multiple resections, where we can put the left hepatectomy, and then for sure there is a high complexity where we can put a resection in posterior superior segments, right hepatectomy, and maybe advanced procedures like ALPS procedures, and maybe resection in severe cirrhotic patients. And we need to know how much a resection is complex, because we need to keep in mind that during laparoscopic resection, the possibility to convert the patient to an open resection is always there. We don't have to be afraid of it, but obviously if we understand the real complexity of a resection before surgery, we may also understand how higher is the risk to convert the patient. And then we will spend a few words about what is the meaning of a conversion in laparoscopic liver surgery. As you can see in our experience, but obviously our colleagues, Dr. Fretland, Dr. Ferrero, Dr. Besseling may present their own experience. In our experience, as you can see, we always have a conversion. Regardless the level of experience, regardless the number of laparoscopic resection, you can see here the green line, the percentage of laparoscopic resection over the total number of resection. As you can see, still we have a conversion. Obviously, conversion rate was higher at the very beginning of our experience. Then probably we had the possibility to lower this rate close to 5–6%. And then when we decided to go a little bit out of our comfort zone to explore more complex cases, we had to deal again with a higher conversion rate, so that we now are close to 10% of conversion rate. And conversion is a very important issue because this may really affect the result of resection and may really impair the outcome of a laparoscopic resection. Here is a paper based on the experience of several centers around in Europe, putting together a little bit less than 3,000 cases. And as you can see here, obviously the complication rate is higher in converted patients when compared with completely laparoscopic patients. And this is pretty reasonable because obviously conversion is usually based on some concern or complication. But what is really important to pay attention to and to keep in mind anytime we face with a laparoscopic resection is summarized in this table. If we look at a little bit more than 200 converted patients, and we divide the reason on conversion in two big groups. One is what is called unfavorable intraoperative findings, meaning that we convert the patient without a real complication. We convert the patient because of the adhesions. We convert the patient because we have some concern about the oncological radicality. We may have a poor access, poor liver quality, or any other reason. Then you can see the 90-day mortality for the converted patient is basically what is expected, below 2%, putting all together minor and major resection. But if we convert the patient with an intraoperative unfavorable event, which is basically bleeding, you can see in this experience is a little bit less than 1/2 of the conversion, then the result for the patient is pretty poor. Mortality rate at 90 days reaches 10%, which is a mortality rate pretty unacceptable at the present time for any liver resection program. So this means that conversion is something that we have to deal with, but it's important to prevent conversion, and that's why it's important to understand the real complexity of a resection. And obviously, if we need to keep into the account the conversion possibility, it's absolutely crucial to convert the patient before any major complication, especially bleeding, happens. That's the reason why when we look at the Southampton Consensus Guidelines, there is an important statement that need to be in our mind anytime we decide to implement our laparoscopic experience. That is, surgeons should develop their laparoscopic liver practice in a stepwise fashion. So it's important that we understand the complexity of resection so that we may face the right operation, meaning the right complexity that is proportional to our experience. And I would say that there is no justification at the present time for surgeons not to analyze the complexity of a laparoscopic resection before taking the patient into the operating room, because we may look at, and we need to look at, I would say we must look at some very important complexity score. And I will show you this course. I will then ask for the opinions of our colleagues, but I think this is something that is really important for the activity of each of us when facing laparoscopic resection. So here is a kind of difficulty, I would say not score, but maybe classification, that is done by Brice-Gaillet experience. This is mainly a classification about the risk of complication. So if we think that complexity and complications go together, then we can consider also this classification as a classification of difficulty. And you can see 3 levels defining how complex is a resection, how risky is a resection, with low risk, considering basically wedge resections and the left lateral sectionectomy. Then we have an intermediate risky procedures, considering the left hepatectomy and the minor resection in the anterior segments, while when we go in the area of the right hepatectomy, of the extended hepatectomies, and the right sectionectomies, including right anterior, right posterior sectionectomy, and obviously central hepatectomy, then we are in the area of high complexity and high risky resections. Another very well-known difficulty score that has been also validated by several studies. I think we have also a specific study from Alessandro Ferrero concerning this difficulty scores, is based on Professor Wakabayashi's group. And this is a real score because taking into account 5 parameters that are tumor location, extent of liver resection, tumor size, proximity to major vessels and liver function, and giving points to these different parameters, we end with a real classification of difficulty ranging from level 1 to level 10, divided into 3 areas: low, intermediate, and high. And this is, I think, a pretty reliable way to understand how much a resection can be complex. And I will show you that sometimes very different procedures have the level, say, the same level of complexity, even if they look very different if we do not apply a complexity score. And finally, we have another complexity score. This is probably what stratifies in a more precise way the level of complexity of liver resection that is based on a multi-institutional experience, has been produced basically in Southampton, looking at the series of several centers. We have in this series Oslo Center, also Center 2. And you can see in this difficulty score is considered not only the tumor, not only the type of the resection, but what is really important to me, there is also the concept of the type of the lesion, the concept of neoadjuvant chemo or not, that is definitely affecting the quality of the liver, and the importance of a previous liver resection. Today we will discuss about low complexity procedures, and we will discuss about instruments to work with the low complexity procedures. And the most important thing probably is first of all to study the case before surgery. This is something we have to work on. We have to analyze the vessel anatomy, including the hepatic artery, portal vein, hepatic veins, study the main Gleasonian pedicles, the hepatic vein branches, the location of the middle hepatic vein, and the Cantley line, the shape of the segment 1, the possible compression of the lesion by portobiliary, by the lesion of portobiliary and hepatic pedicles. And here are 2 very easy video regarding a low complexity procedure, that is the left lateral sectionectomy. What we think it's part probably of the experience of any liver surgeon. But you can see in what happens here if we do not study precisely the anatomy of the liver before surgery, and the second video, what happens if we do analyze the anatomy of the liver. You can see down in the second video an aberrant left hepatic artery from the left gastric artery is recognized and divided before the resection, while on the first video you see what happens when the surgeon didn't study the CT scan before surgery and obviously didn't know there was an artery there, and ended in a severe hemorrhage for entering in the artery. So that's very important. We have to score the complexity, and we have to study the case. Which are the low complexity cases? Are those cases ranging between 0.1 and 0.3 Wakabayashi complexity score, that is including resections minor resection in laparoscopic segments, the left lateral sectionectomy, and these are typical examples of low complexity resections. For example, here we have a lesion in the segment 3, a colorectal liver metastasis, and here you can see how it can be easy to define the complexity by applying the different score. We end by applying the Southampton score in a total score of 2, meaning that we are dealing with a low complexity resection. But we may have a completely different type of resection that may look really different as for complexity, like this one, but still, putting together the score, we have a low complexity resection. And again, you can see here a large adenoma in the segment 2. Maybe this may look like a more complex case, but again, by applying the complexity score, we end with a total score of 3, meaning that we are dealing with the low complexity resection. This is just to remind you that today low complexity, then another round table for intermediate complexity, and the third round table on advanced. Just 2 numbers about how many cases do we have to perform before considering completed the learning curve. This is a very famous paper from Professor Cherchi. Actually, first author is a distinguished Italian colleague, Luca Viganò. And 60 cases were supposed to be necessary to complete the learning curve. Actually, there are very large differences if we consider the pioneers or the new generation. So it's important if you work already in a experienced group in laparoscopic liver resection, or if you have to start with your own case, it's important to consider the complexity. This is a paper showing that we actually need almost 15 cases to complete the learning curve for left lateral sectionectomy. So probably we don't need 60 cases. And here is a paper from our group, and I close with this slide, showing that based on complexity, if we want to consider completed our learning curve for low complexity cases, we are supposed to do at least 60 cases. For intermediate difficulty and high difficulty, other 15 cases each. So basically, based on this experience, we are supposed to do almost 90-100 cases to consider completed the learning curve for any level of difficulty. And I will stop with this. Basically, training in laparoscopic liver resection is mandatory. Every setting of training provides specific opportunities and helps in the development of specific technical and cultural issues. It's important a stepwise and tutored approach in the development of the expertise. And we have to use difficulty score because this is an effective method to define the level of technical challenges and enroll cases according to the degrees of expertise. So I will close this first part. Obviously, I will ask if Professor Fretland or Professor Ferrero or Professor Besseling, if they want to say some words about their experience with complexity scores. Maybe Alessandro. Okay, sorry, we were a little bit in hurry. Alessandro, do you want to comment on difficulty scores? Can we connect with Professor Ferrero? Osmond, do you want to comment on that?
Luca, can you hear me?
Yes, Alessandro. Yes, sure.
Okay, so first of all, congratulations for your lecture. I found it very interesting. I've got some problems when I face with the difficulty score because we made a study about that, and what we found is that we haven't got the ideal complexity score. So actually, I think that establishing the difficulty of a liver resection is difficult. It's really difficult, and probably is half of the difficulty of a laparoscopic resection. So I do think that we need to work again on the difficulty scores, and I think that we have so many variables that are the site of the lesion, the type of the lesion, the type of the liver parenchyma, the type of the liver anatomy, because we know that the livers are different, and there are the type of the patient. So many factors that can impact on the difficulty of the liver resection. So we have to work on it, and I think that we have very good difficulty scores, but till now I think that we have not the ideal score.
Thank you, Alessandro. Professor Besseling, nice to see you. Can I say hi to Mark? Are you with us? Hi, nice to meet you. Osmond, can you comment on the difficulty scores? Because, I mean, you are the pioneer of laparoscopic resection, so I'm sure you made a lot of mistakes, so you know exactly what the difficulty is.
So first of all, thank you very much. And I have to say, I am not the pioneer, but Professor Advin is certainly one of the pioneers. So he also says hello to everybody. But I've learned very much from working close with him. And I think that the difficulty score is difficult to use. And what you need to do when you have starting your program is to have some experienced friend. So you can send your scans to this other expert, to this expert, and just say, is this a good case for me now? I think that should really be a part of the startup. For the first maybe 30 cases you do, just find somebody to ask for advice. Maybe this is the center where you went to training to, because at least in my experience, even using the scores, thinking myself, sometimes Professor Edwin has said, nah, this case is not for you. This is difficult. Maybe we should do this open. So I think complexity and difficulty is very hard to put down in a scoring system. So you can have the scoring system, but I think it's good also to have the experience in when you think this.
So you mean it's important to combine difficulty scores with opinion of maybe more experienced centers or who could tutor you or at least give you some personal idea of difficulty. Am I correct?
Yes, at least for my own learning curve, I'm sure that has been very helpful. And I think it has saved me from some problems, although I have also made some problems myself. I've been saved by listening to more experienced people.
Thanks, Oswald. I think, Mark, you actually have a great did a great work connecting with other centers, right? To rise up the experience of your center and of other centers in your country. So I think we would like to take advantage from your opinion.
I agree with everything you said. So we need for the future. I think what would explain scan forward what
Mark?
in the Dutch
Mark?
program.
Bisogna dirgli che non si sente bene. Mark? Mark? We have a little bit, a small technical problem, so can we fix it and then go back to you? Noi possiamo andare avanti, maybe. Okay. Okay. So maybe we can connect back again with Mark when the connection will be better. So I ask Mark to be patient, and maybe we can start with the technical aspect to rise up a laparoscopic program. So we were saying that laparoscopic ultrasound is really important, probably is the most important single tool to let us face laparoscopic resection. So if we can introduce Professor Ferrero with his topic about laparoscopic ultrasound.
So, good afternoon to dear colleagues, and I'm happy to be aware that all of you are safe and are doing well after this awful period we had. And I'd like to thank Luca for this kind invitation. It's a very great honor for me to be here with you and to participate to this very nice symposium. So, I will talk about in the next 10 minutes, 15 minutes about the principles of laparoscopic ultrasound. And I think this is a very important issue for a surgeon who is facing with the beginning of the laparoscopic liver resection. So actually, I will talk about the technique of the ultrasound. I don't know how to have the next slide. Okay, thank you. And I will talk about the technique of the laparoscopic ultrasound, and of course, I will talk about the indications, and you will see that ultrasound is very useful not only for staging, but I think above all for guiding the liver resection. Actually, something about the technique, I'm still not aware how to proceed with the slides. Sorry for that, but probably I will try it. Okay. So, who is doing that? No? Okay. Talking about the probes, I will not talk about the ultrasound machine because you have different ultrasound machine. I think that you need a high performance ultrasound machine to use it in the OR. And I will spend 2 words about the probes. You know that we started with the rigid probe that actually is, you cannot find it anymore. And we have the flexible probe. And we have 2 kinds of probes that are the 2 ways probe and the 4 ways probe. Però così. Sorry for this, but I cannot move the slide. Okay.
Provi con le frecce forse.
I had just to click on the slide, or what else? That's what I'm doing. Okay. It will be very difficult to proceed like this. Sorry, but I don't know how to proceed with the slides. Okay, then. Yes, probably we are okay. Thank you for your support. And so we consider the movements of the probe, but you know that we have two kinds of probes, which are the linear probe and the convex probe, which is actually what I prefer because you have a better panoramicity of your exploration of the liver, and now is the probe that we are using. And you know that the typical diagnostic scanners operate in a frequency that range from 2 to 18 megahertz. And in the exploration of the liver during the operation, we use it at 7.5 megahertz. But you can change the frequency when you have to go deeper in the parenchyma or in a different level of exploration. Now I will talk a bit about the probe movements because it's very, the first suggestion I have to give you is that you have to move very, very slow when you perform an exploration during laparoscopic liver resection. And you can have some different movements. The first one is the sliding. Sliding can be both longitudinal or transversal. And here you see how you can follow the middle hepatic vein using a longitudinal sliding. So you have the probe on the same axis of the middle hepatic vein, which is, you can see here, this dark line is the middle hepatic vein. This is the port of bifurcation. Actually, you can follow the middle hepatic vein from the IVC going down till the gallbladder, which appears here. So the second way to slide on the liver surface is to slide in a transverse way. So in the same way, we want to follow the middle hepatic vein, but this time we want to follow it in a transversal scan, and you see here the IVC, here the middle hepatic vein, and you move very slowly from the IVC confluence to the gallbladder, and you see here the middle hepatic vein once again going toward the gallbladder. Of course, if you have 4 movements probe, you can use it, rotating it when you want to follow a vessel and you want to follow it in a longitudinal way. So here you got the lesion in segment 6, and you see here the right hepatic vein. Here you see in a transverse scan the pedicle to segment 6, so you can rotate your probe, and you can rotate it to fix the pedicle of segment 6 going toward the lesion, and to see the pedicle in all the path it follows. You have two more movements you can use during your exploration. The first one is rocking. Rocking means that when you have your probe on the liver, you can move it like this to follow, for instance, in this case, to follow the right anterior portal pedicle. So these very, very slow movements allow you to see the pedicle, and here you see segment 5 pedicle here and the segment 8 pedicle there. Just moving and rocking the probe. The second and the last movement you have to be aware is tilting. Tilting means that you can rotate the probe just a bit on the left and on the right with a very little movement to better see what is just around the scan you're having. So here, for instance, again, you got the middle hepatic vein, and you can just turn on the right and the left to see the parenchyma around the vein. So actually, you can, of course, move your probe. Remember that you have many trochers, usually during a liver resection, so you can move your probe from the umbilical on the left, on the right, to have different scan of the liver. Of course, laparoscopic ultrasound has got some technical limits. Exploration of the deepest part of the liver sometimes is difficult, mainly segment 7 and segment 1. You got a less panoramic view compared to the open intraoperative ultrasound. Unfortunately, we have poor quality contrast enhancement, and you have limited movements compared to the open one. So there's a learning curve as well as the laparoscopic resection to be skilled doing laparoscopic ultrasound, and you have to train, and you have to train again to get the best result. I want to move a bit about the indications, because of course laparoscopic intraoperative ultrasound was born to better stage the oncologic disease. But I think that the main role actually in liver surgery is to guide liver resection. I will spend 2 words about the staging laparoscopy. And we made a study which was published some years ago in British Journal, comparing, and this was the first paper comparing laparoscopy and open intraoperative ultrasonography. And what we were looking for at that time was the comparison of the two procedures about the performance in terms of liver anatomy study, staging the disease, and surgical strategy planning. And as you can see, laparoscopic ultrasound and open ultrasound had comparing sensitivity and accuracy rates very similar, and both better than the preoperative imaging. And we had an agreement even in the anatomic landmarks. You see that in the 92% we had the same patterns in laparoscopic and open ultrasound, and a bit more difficult was the study of the IVC confluence. And we published a paper as well on the use of laparoscopic ultrasound in the staging of biliary cancer. And I say biliary cancer because probably is the group of patients which more can can have advantage on the use of a laparoscopic ultrasound, and you see that the overall yield of all the biliary cancer increased from 18 to 24% with the use of ultrasound, and mainly for gallbladder cancer, that half of the patient had a significant useful laparoscopic exploration. But I want to move to the guiding of the laparoscopic liver resection, because I think this is the main topic, probably the main topic even for today. And we know that we had some technical difficulties during liver resection. We have lack of palpation, loss of spatial orientation, we got lack of depth perception, and we have difficult access to the posterior segment pedicles as well. So we try to standardize our technique. Then actually we published some papers about that. And we call our technique US MAP technique. And basically we have 4C rules, because what we try to do is to, first of all, to explore the liver and to compose a 3D mind map, then create a sketch on the Gleasonian sheet of the liver, then of course during the resection to check the way and to correct the direction when we are aware that we are on the wrong plane. And here is a brief sketch that is what we usually do during our resection. We compose a 3D map of the lesion. In this case is liver, a tumor in segment 5, and we have to give some to know where the vessels are, of course. And so we sketch the middle hepatic vein, doing a segment 5 resection with the branch to segment 5. We have to be aware where the right hepatic vein is. We have to be aware where the right anterior pedicle is, and of course, all pedicle to segment 5. Then we create the line of transection on the surface of the liver, like this, and then we do the resection. And just to finish my presentation, I want to show you a brief operation, which is a segmentectomy or 4A and 8 ventral, with the use of this technique. The case is a patient of 80 years old with a liver met exactly between segment 4 and segment 8, infiltrating the middle hepatic vein very close to the biliary confluence, which is there. Here is the relationship between the vein and the lesion. So first of all, we create the sketch, and you've seen here is the sketch of the middle hepatic vein. Now we are drawing the right anterior pedicle there, which is there, and then the branch going to the ventral part of segment 8. And then we draw the line of transection based on the line of the anatomy of the liver. And then we start the transection, which goes through the pedicle of segment 4. Here is the biliary confluence. Here is the lesion, which is detached from the biliary confluence. Then we see exactly the line where we want to cut the middle hepatic vein there. So we can check with the ultrasound the exactly plane we are doing to follow the middle hepatic vein. We cut the branch of it, and then we cut the vein, and this is the segmentectomy at the end of the operation. So I conclude saying that laparoscopic liver ultrasound, I think that meets the surgeon's needs, which are staging the disease, planning your resection, and guide your laparoscopic liver resection, making it safe and I think easier. Thank you for your attention.
Okay, Alessandro, great presentation. I think this is a crucial topic because, as you said, by laparoscopy we don't have the chance to palpate the liver. Many things can come to be a little bit difficult. So, thanks a lot for this presentation. And I would ask maybe Mark, since we had some difficulty with the connection, if now it's okay, I would ask you two opinions. One about your experience with the difficulty scores and with the cooperation with other centers to implement laparoscopy. And what's your opinion? How much is important experience with ultrasound for starting a laparoscopic program?
Thank you, Luca. Very happy to be in this webinar, so thank you for the invitation. I'm enjoying myself. I think ultrasound experience is key. It's really crucial. And personally, we, in the beginning of a liver resection, always have the interventional radiologist in the OR, because in any advanced case, when we do ultrasound in the beginning, we always have the interventional radiologist in the OR, also in advanced pancreas cancer. And then during the OR, we use the ultrasound ourselves to guide the way. And I think everything that has been said for ultrasound is absolutely crucial. For the difficulty scores at the moment, we don't use them. We base it on experience, but I think going forward to the future, we really need better difficulty scores and we should start using them. The problem is now is that we did a nationwide training program for laparoscopic liver surgery in the entire country, and surgeons could select cases and a proctor would visit them to do the case. And we noticed that the smaller the center, the more difficult the case they select. And the problem is they only have few cases in a smaller center. So I think really the selection is the holy grail of starting with laparoscopic liver surgery and expanding safely. So I think it is absolutely crucial. So that is my experience.
Thanks, Mark. Thanks a lot. Okay, maybe since we are with you, we can introduce Professor Besselink. And so, Mark, your presentation about how to set up the operating room to start with the program. So, any mistake in the future is your responsibility because you are telling Italian surgeons how to start a laparoscopic program. Okay? Okay.
No problem.
So, can we present?
Thank you. Thank you, Luca. So I brought my presentation because normally we all bring our presentation and show our best video of the most difficult case in the world. But this presentation is really like the ABC and really like all the stupid questions that you never dare to ask when you start doing this, right? Because we as surgeons, if we start something, we always talk to each other like we've done 1,000. So this is really the basics of the basics. So if at some point anyone thinks this is too simple, I apologize upfront for that. Next slide. Okay, sorry for that. So just a little bit, very briefly. So just to know a little bit who you're looking at. So I did my fellowship in Amsterdam in 2012. So not too long ago, I did a year fellowship HPB. And then in 2013, I went 8 months to Southampton to train specifically for minimally invasive liver surgery. And then I got back to Amsterdam where there was a very supportive group. 2 surgeons had just started with minor laparoscopic liver, but we had a GI surgery team that did minimally invasive vasectomies, a lot of minimally invasive colorectal surgery, pouch surgery. So there was a strong group already for minimally invasive, and I think that is very important, and especially the nurses. Sorry, there's a slight delay in the slides. So, so far in our center, we have done 170 liver resections. I've done myself 170 liver resections. I've done 98 laparoscopic distals and 106 minimally invasive Whipples since that time. And in our center, we've done 255 minimally invasive liver resections. So what we did in this publication, we compared the outcome of laparoscopic liver resection in our center, minor, and then after my fellowship in major, just to see what happens if you send one of your team for specific training. Because I think this is my main lesson for all of you who want to move forward from just a minor liver resection, so from 2-3 and from small wedges to really major liver resection, hemiapatectomy, extended resections, high liver resection. Make sure you get a proper training. And proper training is not one video course, but proper training is really a fellowship, ideally of several months up to a year. So we compared our results. So group A is our center initially of surgeons just starting themselves after 1 or 2 few day courses. And then group B is after I did a serious 8-month fellowship. And you see in red that in the second period, you take on more advanced cases. 60% had previous abdominal surgery. You see you take on more often a malignancy, whereas in the beginning you would do more adenoma, etc. And you see also more often you take posterior segments. So you can increase the numbers because you will operate more complex cases after specific training. So this is the patient selection. Now we go forward. And so sorry, it's really slow to respond to my slides. Here you see minor resection. So of course, then goes down. We did a little bit hand assistance in the beginning, then we stopped. And additional wedge resection also more in the second group because of course you take on more complex cases. And also you see you take on things like 2-stage resection with portal vein embolization, etc. So of course, with more training, you can take on more complex cases. I think this is very clear. And one of the big benefits of getting more advanced training. So here you see some results. Strangely, but actually not strangely, if you think about it, operation time, of course, goes up because you won't be quicker because you'll be doing more complex cases, and blood loss is going down, whereas hospital stays stayed low with 4 days, complications stayed low, and we had no mortality in the second group. So I think with good training and careful selection, you can go forward and get better results. I think this is very, very clear. So now we go to the basic steps. I promised you very simple, very basic steps. And I also like the 4C approach and things that have been said before. And I think this is important to have a standard approach. So first, if you have a case, can you do this laparoscopically? And not meaning, can this be done laparoscopically, but can I do this laparoscopically? And then 2, before you start, and that's why I see many junior surgeons and less experienced liver surgeons struggle. They start the case, they put a trocar, and then they start thinking. So like the mind map for radiology, which I like a lot, you also need a surgeon map. You need to think before, how is the patient positioned? Is it flat? Is it tilted? How much anti-Trendelenburg? And make a drawing before you start. Where do you place the trocars? Dus the trocar position needs to be really carefully accessed, and you need one hand between every trocar. So the width of one hand between every trocar. And think about how you're standing. You should be comfortable looking at the screen straight in front of you. I still see surgeons looking like 45 degrees up to the ceiling. You will damage your neck. So make sure you think about the position and be very comfortable. And as the last point, make sure that the trocars are in a line, like in a smiley. a soft curve, and then always one hand between two trocars. You think this is basics, but many people make big mistakes here. And if in a laparoscopic case, this is wrong in the beginning, it's going to be a nightmare. If you get it right, it's a very comfortable operation, and it's often more comfortable laparoscopic than open. So I think this is really important, and this is often overseen. So this is the first. Then, so a little bit about the instruments. So of course, laparoscopic ultrasound. Then make sure you get training how to use a laparoscopic Pringle. I don't have the time to explain in detail, but there are several ways to do a laparoscopic Pringle. Then laparoscopic CUSA. You also need to get training in working with that. The laparoscopic CUSA in the beginning feels like working with a pen that is too long. And you see here a normal scissors, but I think it's really important to have a laparoscopic CUSA. That's one of the main things that why laparoscopic liver surgery still has a benefit over robot liver surgery, because you have a very good CUSA. Can you progress the slides, because they're not working for me, the slides. Can you push forward? So the harmonic, I like the harmonic, but you can also use ligature or thunderbeat. Just make sure you know the instrument very well. They all have a benefit and a downside. Laparoscopic bipolar, for me, this is a crucial instrument. If you want to stop bleeding, the Guyet clamp is very important. I think every liver surgeon should have it. Can you help me with the slides, guys, because they're not progressing? A laparoscopic endoretract number 2, and this is really important. You see it here at the bottom. Many of you have the endoretract 1 or a liver hand, which is straight, but this one has a curve. You can curve it, meaning like your hand in open, you can pull the liver to the side rather than push it down. And the endoretract 2 that has the curve here, and you can manipulate it, that's a very important instrument and makes your life very easy. Then, of course, the Hemolock clips, and most of you will know the Hemolock clips. So, sorry it's going so slow. I'm trying to progress the slides, but they're not working. So finally, these are the last two. One is called the pinky finger. Many of you may know it. It used to be a gold finger, but they don't sell those anymore. This is a flexible tip. You control it here, and you can put a vessel loop through the opening. So for tunneling the portal vein or doing a hanging maneuver over the caval vein, this one is very nice. And the company that now sells them is Bariatric Solutions. It's called the pinky finger. And then finally, I think these laparoscopic bulldog clamps, especially if you have a bleeding, you just put the clamp on a vein, or if you want to check, you can put it on hepatic artery, segmental hepatic artery. I really find them very useful. So the operating room setting, I know many of you work in great hospitals and have nice rooms like this. We are also very happy. We have 21 ORs like this, and every one OR we have 3 or 4 flying screens. I think this is crucial. The surgeon who's standing on the left side of the patient should have a screen straight in front of him or her, and everyone has their own screen. I still sometimes see operating rooms with one screen in front of the patient or on the side, and where residents have to stand for 6 hours with their neck in a curve. And to me, that is really not acceptable. So everyone should be able to look straight, 30 degrees down, to just think of your neck. Because when you're young, and I am young, you still think you're very strong, but you will damage your body. So make sure you get this organized. French position, it can be nice. I usually stand between the patient's legs. You can turn the patient 45 degrees or 60 degrees if you like. But often you can even do it with the patient in a flat position. So the positioning of the trocars, I already mentioned it. French position, you can use a beanbag, one hand between the trocars, and usually the trocars need to be a bit higher than you see in most papers. So mostly in the literature, you see the trocar position like this, for instance, for right hemi, but I actually think this is too low. These should go up there, should be a bit higher. of course, depending on the size of the patient. So again, for planning, look at the scan, look at where the rib cage is in relation to the liver, and then place the first trocar correctly, then look, and then make a semicircle. So there's some delay. So this is a photo for trocars for the right hemi. You can see them here in a curved line. This trocar here is for lifting the liver off the caval vein. This is not a standard approach, but this one you can use for a sort of reverse hanging maneuver. And you see here on the screen, you see the pinky finger, which is used for reverse hanging, so pushing up the liver so you do not lose your direction. And I think this is another thing, you can easily lose your direction doing long laparoscopic cases. And it's very important to lose ultrasound and landmarks to keep your bearing straight and don't go in the wrong direction. Okay, next slide. Here is a picture of a quite obese man. In the Netherlands, people are slim, but still we have some big ones. Here you see the pubic bone. This is the patient's head on the left side. So the right side is pubic bone. This is the umbilicus of the patient. So you see how high the trocars are placed. And I know for many surgeons, when they start, they don't think of this. For many of you who are experienced, everyone will know this. But this is a point that many people miss. Next slide. So here is the same patient in anterior view. And you see, this was a patient with a small liver, but you see how high the trocars needed to be. So of course, this is an extreme case, but this is just to get your attention. Next slide. So laparoscopic ultrasound, we spoke about it. And the round ligament here and the triangular ligament, those are your friends. You can use them to rotate the liver. And I'll show you a few photos. Next slide. So mobilize the liver. So for instance, if there's a right posterior lesion, you want to do a metacystectomy, it can be really useful to mobilize the full liver on the right side and to counterclockwise, so down like this, rotate the liver. So segment 8 becomes 7, 7 becomes 6, and 6 becomes 5. You rotate the liver towards you. And then via epigastric port, you can use the endoretractor, the one that could curve, to push the liver medially. In that way, you can fully rotate the liver to the left side of the patient. So it becomes to the left side of the caval vein. So that is really useful, and to do metacystectomies of the right side of the liver. Next slide, please. So this is just a very simple example. You see here, a metacystectomy has been done of the right side of the liver, segment 6-7. And you see here, we rotate back the liver, and the end of the resection, you see nothing. So I know many surgeons who try to do a metacystectomy, you see them working here with the liver in place. But if you mobilize the liver fully, rotate the liver, do the resection, and rotate the liver back. I think this is an often overseen trick. All the experienced surgeons in the audience will know this, but maybe from the junior surgeons, this is interesting. Next slide. Of course, you can use a Pringle maneuver. I know many surgeons that never use a Pringle maneuver. Myself, I always use a Pringle maneuver. Everyone has a different schedule. The one we use here commonly in Amsterdam is 15 + 5. We use a long umbilical tape, which is placed around the ligaments. It's taken out of the body through a 10-12 port, and over the tape, we place a 12 centimeter surgical drain. So the 12 centimeter surgical drain is a thick drain, and it's put back into the abdomen, and then it's pulled out. The tape is pulled out via the 5 millimeter left flank port, so very dorsal port on the left side of the patient. So you can pull out the tape, but you cannot pull out the drain. So basically, by pringling, the surgical drain is pushed onto the ligament, and you can have outside control of the inflow. And I think that is a really useful Pringle trip, but there are many other options to do the Pringle laparoscopically. Next slide, please. So step 4 for the hemihepatectomy, I would stay to the basics, so I will be very short. That there are mainly 2 techniques. Next one, please. So there's the hilar dissection, basically the traditional approach for open, where you take down the gallbladder cystic duct artery and then go to the hepatic artery and the portal vein. So basically a traditional open approach for hemihepatectomy. that you can use laparoscopically. Next, please. And you can use the anterior approach, where you start with the gallbladder and then the Pringle, and then you go from the top down to the bottom, and you staple across the artery, portal, and portal vein and bile duct. But this one, of course, needs really good ultrasound. You need to be 100% sure of your anatomy, and that's the caveat of the second approach. Next one, please. So for metastacectomies, I think you already saw an example on the screen. Many people do the metastacectomy like this, with a transverse line at the top, like you do open. But I think for laparoscopic, the metastacectomy should be like this. So with one top, so you make straight lines through the laparoscopic instruments, because laparoscopically you cannot do this. Laparoscopically you can only do this. So you need to turn the square so it points upwards towards the heart. And I think this is very useful, simple trick for starting surgeons. Otherwise, at the top you have the problem, because you cannot make a left-right line on the liver. Next one, please. So the parenchyma dissection, what we like to do is the drawing with the diathermy as well. Go down 2 centimeters in the liver with the harmonic, and then work with the harmonic in one hand, or thunderbeat, or as you like, and the QSA on the other hand. So it's a two-hand approach. The surgeon has both harmonic or on the other device and the QSA in one hand. So I think that's very simple. Open the liver and make sure you go down the fairway, as we call it. So open it up like a book, and stay in the correct line. And I really liked, as I mentioned before, the ultrasound check of your position. Next, please. So of course you can use several techniques for diathermia, but just think a bit what you like. You can do on the tip of the QSA. When you have the diathermia on the tip of the QSA, you can do small vessels with that. You can use the harmonic for bigger ones, clips, hemolocks, and of course vascular stapler if you want to transect, say, the right hepatic vein. So think a little bit about what is the quickest and what you would like to use. The next, please. So this is just a very simple picture of showing the hemiampectomy. It's really nice. That's why I show this video, to work with the vessel loops. Ask the nurse to cut them twice in half, so a quarter length. Put hemolocks on them for the orientation. Use hemolocks, and of course you will all know always 2 hemolocks on the staying inside of the patient, because 1 hemolock is not safe. You always need 2 hemolocks, and alternatively you can do stapling. You see a specimen, and this again to illustrate to you that trocar position is high, can be very high. Next one, please. So there are some few very simple tips. You see this lesion here. What is very simple is to use a hanging maneuver here with an umbilical tape. So you lift up the liver, and that makes the dissection much more easier. So a hanging maneuver can be for very peripheral lesions, just a very simple basic trick. Next, please. So the removal, I know many surgeons that make an incision at the location of one of the trocars. I think that can be okay, but please keep in mind that even for a small incision, if it is not, if it's in the midline, at least you have a 10% risk of incisional hernia, 10%. And if you do a good Phalansteal incision, and I recently noticed that people do a Phalansteal with a midline fascia, but that is not a Phalansteal. A Phalansteal is a left to right transverse fascia incision, and then you cut between the rectus muscle in the middle. So fascia has to be left to right. If you do a good Phalansteal like that, there's only 0.2% incisional hernia rate. And of course, you all know that the hemiapectomy specimen can easily go through a Phalansteal incision. So I think most of you will do it, but I'm really a big fan of a Phalansteal incision. Next one, please. So I think this is already the final part. So 4 points. So first, of course, train your team, but train one, or at least one really good. Send them for several months, like an expert center, like the ones you know. But also train the OR team. Take your nurses seriously. Take 1, 2, or 3 of the nurses with you when you visit the center for the first time. It's really crucial. People forget it. Then ask really in detail about the equipment. Don't just start doing it. Make sure you get the right stuff. Talk to your radiologist for the ultrasound. select your patients very well. Dr. Fredland said it, ask someone who's more experienced in the beginning, because that's often made mistake. And then finally, before the surgery, make a map, prepare your strategy in detail, and think about how to position the patient, think about the trocars, because it will make your life a lot more comfortable. Next slide, please. So thank you very much for your attention.
Okay, thanks, Mark. It's a great presentation. Actually, I heard your presentation several times about how to start, and I think it's really, I mean, inspiring, because you actually take every single issue, and I think it's very important. We are a little bit late. I would ask Osmond and Alessandro if they have a very 15 seconds comment. What is for you something really important to start? One single thing, you Osmond and Alessandro, so that then can we proceed? One single thing.
To bring the whole team for the training and the whole setup and learn positioning, the trocars, the equipment, not just to go alone, because if you have the team with you, your success rate is much bigger.
Yeah, I totally agree. Alessandro?
I really appreciated the Mark talk, and I do agree with everything. If I should say one thing, ultrasound.
Okay. You don't sell ultrasound, right, Alessandro? You don't have a company of ultrasound.
No, unfortunately.
So this means you really trust in it. This means you really trust in it. Okay. Thanks, Alessandro. Can we present Dr. Fredland about transaction technique? Because so far we know how to prepare everything, but we also need then to cut the liver. This is what is called a resection. So can we?
Dear friends, Luca, thank you so much for the invitation. It's really fun and an honor to see you guys and to take part in this program. So a lot of very wise things have already been said, and I will just try in 10 minutes to summarize how we consider the parenchyma transaction. First of all, I think that you need, as Professor Besling said, as Mark said, really, it's not only about to transect the parenchyma. It is actually about how you have positioned the patient, what kind of preparations you made of the Pringle, of the central venous pressure, of the whole team. So I will just briefly go through some things first. But first of all, I just also, to introduce myself, I am a consultant HPB surgeon at Oslo University Hospital, where I trained laparoscopic liver surgery and laparoscopic HPB surgery together with Björn Edvin, who has been working in this topic since the late 1990s. So in Oslo at the moment, we, I think, have a total material of around 1,300 laparoscopic liver resections. And we are now a little bit behind you, Luca, in the numbers. And we, of course, will work on that to follow up the great increase that you have in laparoscopic numbers at the moment. Okay, how to begin laparoscopic liver resection. So we heard this now, we watch videos and watch more videos, and then your wife starts complaining, and then you watch some more videos, and then you can travel to an expert center. You need to do that. You need to take training courses, and most of all, you need to build a team. So you should not go training alone. You should go with your surgical colleagues, and also your anesthesiologist and your nurses need to be in on that. We talked about selecting cases. Is there a previous operation? Is there a healthy liver? Is there a superficial tumor? And as Mark said, is this an operation that I think that I could do laparoscopic? Just now an hour ago, I needed to go and see to a patient because this Monday we did a really small laparoscopic liver resection. Should be very simple and low risk, but the problem was that I made a hole in the patient's small bowel when entering the abdomen because I was too quick and a little bit stupid. This is also one of the things you need to really figure out. If there's a lot of adhesions, it will ruin your nice laparoscopic liver resection. So perhaps not choose patients with a lot of previous operations for the beginning. So to plan the resection, trocar placement is really important also for the transection of the parenchyma, because you have to be able to get good lines. You need to have good working direction. In Oslo, we do not stand between the legs. We stand on the patient's right side for most of the procedures. So in this L-shaped or curved setup, it will be for a posterior resection. The surgeon will use these two trocars, the camera will be here, and the retractor will be here. And we try to keep it very simple with few trocars. So we mobilize the liver a lot so that the instruments that you are using need to be able to reach the posterior part of the resection bed before you start the operation. This is also very important for the transection. And I say Pringle, in this center, we did not usually use a lot of Pringle, but we are now really, we have converted, we use more Pringle now than ever before. Still not for every case, but for most cases. And I think the most important thing is because the Pringle lets you really see what you do. You can operate with full control, and that's very valuable when you learn and also when you do difficult stuff. So this would be for a segment 8 resection, a nice setup for our trocars. Again, there is the surgeon on the right-hand side working like this. To Mark, I think you left Mark, but you don't have to do a diamond-shaped resection because you have this trocar here, up here, and you can do really also a straight line in the back if you want to do that. So I think you can plan your resection line a little bit like you find useful if you just use all your trocars and mobilize the liver. I just drawn in here the direction for the surgeon's trocars and the direction for the camera and for the assistant. This is then for the posterior section. We see that we have these two here. In this setup, of course, the number 4 is used to retract and rotate the liver so that you get the tumor to be somewhere here, and then again you have a good direction. Positioning, we use this kind of 30-degree position for a lot of our operations. We put 45 degrees in more posterior resections, and we tilt the table quite a lot if we need to do that, both to have the patient more flat and to have the patient more steep. And this again, typical high trocar placement for a big patient. So for the transection, you need first to do the mobilization. As I said, the instruments must reach the posterior part of the resection bed. We actually use a 3-finger retractor, but after Mark showed the 5-finger with the angles, it reminded me that we could use that also to benefit from this angle. But the rotation of the liver and the mobilization of the liver is super important to be able to do a good job. We put the Pringle on with the drain outside, and we just put a clamp outside on the liver. But again, this is very individual. The Pringle can be difficult to put on. And there is one rule in our center: you never do it if there's resistance. That is also for the Pringle and also when you dissect in the liver, but especially for the Pringle, never if it's resistance. And you need to open the pars flaccida and you need to see what you're doing so you don't do any disastrous damage. So this is how we mark the resection margins with the cautery. We usually have straight lines here. Oops. We have straight lines here and here, a little curved here. And then you see that when you mobilize the liver, you rotate it, you get a better direction to work in this line. So you have to mobilize to do that nicely. And then the first part of the transection, We would use only the energy device. We are very happy with using bipolar energy, but as Mark said, you can use whatever you are comfortable with as long as you know the instrument very well. Also, you need to see, no matter what instruments you're using, you need to individually look at how this liver responds. Sometimes you need to burn more, sometimes you can be quick, sometimes we use a knife, sometimes we only crush clamp really and without any cutting. And look how the instrument is closing. What happens? Does it tear the parenchyma when you close it, or does it close nicely and leaves only the vessel inside there? We also use the word open the book a lot, and you see here the assistant just pulling the resection line from the very beginning. We can look down the fairway or look into the open book, as Professor Edwin would say, and to get a good view of the resection line. So we would then do this line, we would do the other line here, we will do the transverse, and we will look for usually the feeding portal vein to the segment, which will come in this area here. So when we get deeper in the liver, we will use the aspirator. We are using the Olympus Sonosurge aspirator. You could use the CUSA, you could use a Suring device or whatever aspirator that you prefer, but we use aspirator quite a lot. We combine it with clamp crushing and bipolar sealing, and you dissect nicely every structure, and you decide if you want to just seal it, if you clip it, or if you need a stapler. And I think this is a very important maneuver, to use a dissector to get really around the vessel, so you see how big it is, so you see that it's not really going straight into a much bigger vessel that you will tear, and then you put a clip on like this. Also, when you are doing the parenchyma transection, I am very happy to use a Surgicel device, to a Surgicel patch or some kind of patch, which is not expensive, but just to put here to cover any venous bleeding, to compress that for a couple of minutes while you do something else, and then you go back there, and usually the small bleeding has stopped thanks to the blood collecting in this one, and thanks to the Pringle.
Okay.
Yeah.
Osman?
Okay, and I have some videos that we can go back to and see afterwards.
Okay, thanks, Osman. You actually said about the Pringle maneuver, and you suggested to use it. I personally think that this is an important suggestion, especially starting with the laparoscopic program. You said Pringle is important to see what you do, and I totally agree with it. So thanks for this consideration, which I think is very important. Do you use Pringle in all cases? Do you start and then you decide what to do? What's your attitude with the Pringle?
So if we expect, let's say, a medium or a high complexity case, we will always prepare the Pringle. If we do something really that we expect is quite simple for the surgeon, we would start the resection and usually just do a quick resection with the ligature and the aspirator, and not prepare the Pringle. Sometimes we will add the Pringle later, but in my experience, if you need the Pringle because of bleeding, it is too late to put the Pringle. Then it's better just to finish the resection really quickly, and then the bleeding will usually stop when you have the specimen out and you can compress it. But for everything that's not easy, really easy, we will prepare the Pringle in advance.
Okay. So it could be correct to suggest beginners to prepare for the Pringle, so that they can be ready for stop any bleeding at the very beginning, even if maybe facing easy cases, because it may happen that at the beginning of your experience, maybe you don't have the right experience to understand if it's easy or not.
Absolutely, that is the exact point, because we are in a center where we have a big experience, and always we can call for help with from a more experienced colleague. So then we can, I say, allow this practice. But also, I think when you're training, you should always prepare the Pringle, and our fellows are learning to always prepare the Pringle, because they cannot, as you say, assess if this is going to be really problem or not. And also, you need to have experience to actually put the Pringle on. So I completely agree. And this is what something that Professor Brice-Gaillet told me once when I was, let's say, I was younger and more a little bit cocky, and I said that in Oslo we don't use so much Pringle, and he said, well, my friend, it's easy for you because you can always call for the experienced guys when you make trouble, but if you are alone and you're starting this up, you must always have the Pringle. And this is really something I took as a very valuable lesson.
Thanks, Osmond. Alessandro, do you agree on this? I don't know if you.
Yeah.
Okay.
Yes, of course. I do agree, and we are performing more and more resection with the Pringle on.
Okay.
And in open surgery, usually we didn't do that. And I think in laparoscopic surgery, you want to see really better, and we usually put the Pringle on.
Okay. Thanks, Alessandro. Okay, so I think we can proceed now with some videos. Oh, Mark, do you use Pringle maneuver? Do you like it?
Yes, thank you. Yeah, as I mentioned in my talk, we use it routinely. But I know of liver surgeons who say they never use it, but they are probably better than myself. But I use it in every laparoscopic case, which is not very minor, and often also just place it, because I also think it's good, better safe than sorry.
Okay, I totally agree, because my personal opinion is that we need to be wise surgeons. Then if we are also good surgeons, that's fine, but the important thing is to be wise. So maybe you don't need to be a master. It's enough to be a medium level surgeon if you are wise. Okay, so I think we can present some videos now. So for our colleagues, how to work with procedures and steps. Maybe we can start. Actually. Okay, so we were supposed to start presenting patient position and trocar position, but this was already well addressed. So I think we can present how to mobilize the liver, maybe something about the Pringle, and the use of indocyanine green for an easy case, that is a left lateral sectionectomy. I will not present these videos because I don't want to be too boring, and Dr. Ratti will do for sure a better job than myself. Please, Dr. Ratti.
Well, I don't think that I will be better than you, but anyway, I will try to do my best to present this video. Which tries to reproduce what we generally do in order to approach lesions in the right posterior sector of the liver. This is obviously not an easy procedure, but we have chosen to show you this kind of procedure since we think that it summarizes many steps and procedures that are very useful in order to implement a program of laparoscopic liver resections. So we have called this video the theory of relativity because what we try to do is to try to commute a posterior superior lesion into an anterior one. This is the case. You see it was a lesion located in the superficial part of segment 7. What we generally do is even to have a look at the coronal CT scan of the patient in order to really understand where the lesion is located. This is how we generally position the patient in the operating room. You see open arms and open legs, with the first operator standing between the patient legs and the first assistant on the right side of the operator. Obviously, the operation starts with the inspection of the abdominal cavity. We start with the adhesiolysis of small adhesions between the gallbladder and the colon. Please note and always think about how to behave with the gallbladder. And the first movement of mobilization is the movement of up to down, meaning that you have to pull down the liver, because when you start a liver resection, generally we have the feeling that the liver is located up in the abdomen of the patient himself. So during the first phase of the procedure, what you do is to cut down the round ligament, the falciform ligament, the right triangular ligament, and the superior part of the coronary ligament. So this is what we call up to down mobilization, and the main aim is to pull down the liver, as I was telling you before, because in order to have the liver closer to your eyes, this part of the operation is particularly important. So we cut the falciform ligament. You have to pay attention not to cut the round ligament too close to the liver itself, otherwise you will have the falciform ligament in front of your eyes. And then we generally use the epigastric trocar in order to cut down the coronary and right triangular ligament. You see indeed that in this part of the procedure, the first operator is using his right hand with the epigastric trocar. We continue the mobilization until the right diaphragmatic vein, which is generally well visible, and it is a very good landmark for the position of the right hepatic vein. So first of all, it helps you in order not to injure the right hepatic vein. And secondly, helps you in order to understand where you are going with the mobilization. Then the second movement is the counterclockwise movement. In this phase of the liver mobilization, we cut down the inferior part of the coronary ligament, and then we expose the bare area of the liver. The main aim is to transform and then commute the posterior superior segments into anterior segments in order to have the transaction plane really in front of the operator eyes. So as I was telling you before, we start from down to up in this phase of the procedure. We have the inferior vena cava, which is located in the right part of the screen, and the kidney in the inferior part. You see very well in this part of the procedure the concept of the caudal view of laparoscopic approach, since you see the liver from behind, and with this kind of movement you progressively destack the right part of the liver from the right diaphragm. You expose the bare area of the liver, and with this kind of movement you manage to move the right part of the liver towards the left. This is the vision from above. You see again the diaphragmatic vein, and it is very useful. I stopped the video just for a second to tell you that it is very important, as Professor Besseling was telling you before, to use the gold finger or the pinky trigger or whatever, anyway, an articulated endoscopic finger, which is very useful both as an element in order to retract the liver, and then as an element of dissection, as you are seeing here. So with this kind of instrument, you both manage to pull and push the liver without harming it, and then you even manage to use it as a finger. And this is the final result. You see the lesion that was initially located in segment 7, it becomes really in front of your eyes. And the concept that we generally apply for laparoscopic liver resection is to obtain a surgical field which is in line with your eyes. First of all, because this is much more comfortable instead of having a field which is not really visible. And then, obviously, it's much more safer since you manage to access the transaction line and to control any kind of bleeding in a safer and more accessible way. Then, after the part of liver mobilization, obviously the liver resection has to start, but before, we always prepare for Pringle maneuver. As we said before, especially for beginners, it is very important to have the possibility to clamp the hepatic hilum in order to control the bleeding, and this is the way we perform the Pringle maneuver in an extracorporeal way. Then the liver resection starts. You see, this is the useful and the most frequent combination of instruments that we use. We have our lesion in front of us. We use the energy device, so the Thunderbit form the most superficial layers of the liver parenchyma. We clamp the hilum very frequently. You see that this maneuver is very easy to be performed. It can be performed even from the assistant. And then the transaction starts with the use of an ultrasonic dissector, which is held in the right hand of the first operator. But when the team is very skilled and very confident to work one with another, you can even divide the work with your first assistant. And this is the final result. So you have the transaction line at the end of the resection, which is really in front of you. You can check the hemostasis, control the biliostasis, which can be done in a very comfortable way since you have all the surgical field in front of you. And then, obviously, you place the liver back in its original position. And then, well, these are the final results, but nothing, really to be underlined. And then the third movement that can be done is something that was imported in the laparoscopic approach by open approach, meaning that you mimic what your assistant does in open approach, pulling the liver toward the left part of the abdomen of the patient. This is a case, you see, this is not an easy case as well. It was a really deeply located lesion in segment 7 with an important contact with the right hepatic vein. But the patient was lucky because he had an inferior right hepatic vein. So the plan was to perform an anatomic segment 7 resection with the section of right hepatic vein, since the patient had an inferior vein that could be used to drain segment 6. Obviously, in this case, you have to perform a more extreme rotation of the liver. You really have to pull the right part of the liver towards the left, because what you have to do, what you are supposed to do, is to rotate the right part until the direct visualization of the right hepatic vein itself. In this case, we decided to prepare the dorsal pedicle and to clamp selectively the dorsal pedicle, but you see that the Pringle maneuver was prepared as well. So in the lower part of the screen, you see the segment 6 that was preserved, and the segment 7 in the upper part of the screen, and the limit between segment 6 and segment 7 was the transaction line. What we did was to transparencyally isolate the portobiliary pedicle for segment 7. And then, as I was telling you before, to isolate and transact with the use of a vascular stapler the right hepatic vein, because the segment 6 was still drained by an inferior hepatic vein. And this is the final view. You see the inferior vena cava with small hepatic veins sectioned and completely exposed, and then the retrieval of the specimen in an endo bag. Okay, so this was the first video. Oh, sorry. Then I think that we want to comment at the end. So I move to the second video very quickly, and then we can do a brief discussion at the end. This is the case. You see, it was a patient with an intrahepatic cholangiocarcinoma located in the left lobe of the liver, and in particular in segment 3. At the very beginning, what we had planned was a resection of segment 3 if this kind of procedure was oncologically radical. In this kind of procedure, what we wanted to do was to use the endochannine green in order to understand if the lesion was really completely located into segment 3, or it was in the vascular territory of segment 2 and 3, in order to understand if left lateral sectionectomy was a more radical procedure. So what we did is what we generally do for resection in left lateral sector. So we preserve the round and the falciform ligament, since they can help in suspending the liver. We isolated with a very small dissection of the hepatic parenchyma along the falciform ligament all the branches, the portal branches for segments 2 and 3. We isolated them and hang them on a vessel loop. And then we clamped selectively every pedicle for segment 2 and 3. And at this point, what you can do is to ask to inject endochannine green. And what is supposed to happen, and effectively it happened, so we did right in this case, that the right part of the liver, so the right hemiliver and segment 4, were marked with endochannine green. You see this is a bit accelerated, of course, and the green went in right hemiliver and segment 4, while the left lateral sector did not receive any endochannine green, since we had previously clamped both branches for segment 2 and branches for segment 3. And when we raised up the left part of the lobe, we see that the segment 1 was green. Then I stop just a second here because it is very important. Okay, so you see that when we removed the clamp for segment 2, we checked and the lesion was located exactly in between segment 2 and segment 3 on the lower part of the left lobe, meaning that if we had performed an isolated segment 3 resection, then we would not have been oncologically radical. So that's why we decided to perform a left lateral sectionectomy. At this point, obviously, what we did was to transact the branches for segment 2 and segment 3, but this is, we think, a very good example of how the use of the endochannel green can help in be really oncologically radical. In this case, in order to understand which was the real topography of the region. But even in cases of hepatocellular carcinoma, where an anatomical resection is oncologically required, then it is very useful. Now we can stop a second, because if you are a bit patient and wait after a while from the injection of the endochannel green, then obviously the endochannel green is secreted from the liver, and then you manage to visualize the main bile duct, which is something very useful both in surgery of the biliary tract, but even when you are in doubt about a possible injury of the main bile duct itself, or a contact of a lesion with the right or the left bile duct. You can see it here very clearly. We have the right part of the liver which is raised up, the segment 1, and then the transaction line. Even for a relatively easy procedure, we always use the same combination of instruments, because we really think that left lateral sectionectomy is a good field of application and gaining of expertise of how conduct the liver transaction, with a good combination of instruments, of ultrasonic dissector, bipolar forceps, and energy device. So our suggestion is during the learning curve to try to apply the same principles even for easy procedures. Obviously, the procedure ends with the visualization and the isolation of the left hepatic vein, which is then sectioned by the use of a vascular stapler, and then the procedure is finished. You see the final view of the procedure with the falciform ligament, which is left intact, as I was telling you before. Okay, that's it.
Okay, thanks. I just want to show you, because this is what we think is interesting about endochannel green. You see, the real anatomy, the real borders of the segment can be seen. For example, if you look at here, you see how on the lower part of the left lobe, it's really, where is it? Here. Okay. Okay, you see the lesion is exactly between the two segments on the lower part of the lobe. And that's interesting, because then if we go to see the same lesion on the other side of the lobe, you see the segment 2 seems to be very small. So the endochannel green, it's really important probably when we want to perform a real anatomical resection. Okay, so I think we finished. Okay, any comment on these videos from Mark, Alessandro, Osmond? Do you have experience with the endochannel green? Do you believe in it or not?
Yes, well, we have a study running from Leiden and Amsterdam. The MIMIC study is a nationwide multi-center study where we give 10 milligram of ICGG 24 hours before surgery for colorectal liver metastasis. 24 hours.
Okay,
and
so
then
you mean
you see like a rim around it, and the study is to see whether radicality is superior. So we use it only for that. We don't use it during surgery. And recently I used it in a case where we had to do a near total laparoscopic pancreatectomy in a 6-month-old child to visualize the bile duct, to make sure we did not damage the bile duct when we removed the pancreatic head around the bile duct. Of course, we had to take a cup of coffee because it took 20 minutes before the bile duct became nice and green. But I think it's something we are learning to use, and I really think it's something for the future.
Okay, thank you. Yes.
Luca, if I can say, I think you showed us very well the real use of ICG, because I think that the real utility of this procedure is to understand the real anatomy and to perform a complete anatomic resection. Because if you clamp a pedicle, you see the line, the demarcation line on the Grisonian sheet, but you don't know inside the liver where is the exact plane. So I think probably this is the best way to understand the exact plane in an anatomic resection. So I think may be useful for HCC.
Okay, thank you. Osmond,
Yes. We just started using ICG a couple of weeks ago, almost. It's very new to us. We are really liking it a lot, both for giving it either 24 hours in advance for colorectal metastasis, 1 week in advance for hepatocellular carcinoma, and for anatomic resections. Like I did a segment 7 anatomical resection 2 weeks ago, and I gave ICG after we took the pedicle, and had very nice help to find the right resection line. Okay. So we really appreciate the ICG. I think we are late adopters just with the Pringle, but we are now catching up.
Okay, thanks a lot. So now we have videos from Mark, from Alessandro, from Osmond. Mark, would you please present your video?
Osmond first, because mine is not yet in the system.
Okay, so then Alessandro, do you want to present your video, or Osmond, who is ready?
You can choose, as you want.
Okay, so Alessandro, please, let's go by alphabetic order.
Okay, I will not show you a very easy case, but I think it's very interesting because you will see all the steps to do a safe resection. As you've seen, this is a metastatic lesion in segment 8, in the dorsal part of segment 8. This is the position of the trocars. So first of all, let's check the anatomy. Here you see the mark, I hope, yes. You see the pedicles. This is the right anterior, the ventral and the dorsal branch. And then the right hepatic vein here. And as you can see, if you follow the right hepatic vein, you will have a good margin on the metastatic lesion. So the operation we are scheduling is a segment 8 dorsal resection. So first of all, we pass the Pringle. This is the way we do it. We do an intracorporeal Pringle maneuver. We pass the sling, then we put the tourniquet. Then we go to the right liver mobilization, as Francesca told us. We start with the falciform ligament. Then we dissect the caval confluence, and we find the space between the middle and the right. Then we stay above the right, and we pass for 2 centimeters the coronary ligament there. Then we stop from above and we pass from below. So we start from the IVC. This is the way we do. We find the right border of the IVC, then we dissect the border until the diaphragm. Then we move on the right side, we cut the triangular ligament upwards until the IVC, and we reach the section there where we started above. So we stop the mobilization there. We don't need to isolate the right hepatic vein. We don't need to cut the Makuuchi ligament. Then we start with our sketch. Here you see the right anterior branch of the right liver. So we draw the line where the plane is on the right anterior branch. Then you see that we will mark here the dorsal branch, which is going to the lesion, and we will need to cut this branch at its origin. And then we draw the ventral branch. You know, there are two main branches, the ventral one and the dorsal one is segment 8. And of course, we want to spare this branch, and you will see that we will succeed on this. And then, of course, when you do a resection like this, you have to be aware of the line of the segment 5 pedicles, and we are drawing here the plane where the pedicles of segment 5 are. So you see the right anterior, segment 8, and segment 5. And then, of course, we need to be aware of the plane of the right hepatic vein, because we want to follow the right hepatic vein to choose the right plane within the liver and to have a good margin on the lesion. And here is the line of the right hepatic vein. So we try to draw, as you've seen, all the landmarks of the resection, and then we draw the line of our transection. And we start with this. So what we want to do is to reach the pedicle of the dorsal segment 8, then to clamp it and to check the ischemia, and then follow the ischemia to reach the right hepatic vein. So here, as you can see, it's not so difficult to reach the pedicle where we wanted to reach it. Here is a small branch that we cut. And then we can isolate the pedicle. Pedicle is there. You see probably the origin of the ventral, which is pair. We put a vessel loop behind just to have the control on the pedicle, and we clamp it. Then you see the ischemia here, and we follow the ischemia to complete an anatomic resection of the dorsal segment 8. We need an anatomic resection because we have to ligate the pedicle at its origin to have a good margin. So we clamp, we clip the pedicle, and of course we cut it. So once you cut the pedicle, your attention is to be paid to look for the right hepatic vein. And it is crucial because this will represent your plane of dissection to finish the resection. And you see a vein there, but you don't know if that's only a branch of the right hepatic vein or is the main trunk. So you put again the probe, you see the lesion there, and you see that your transection line is going not at the trunk, which is there, but only on a branch. And then you check the pedicles, you see the ventral, which is completely there, and the dorsal, which is cut just at its origin. So the dissection is moving to the right hepatic vein, which is there, finally. And this is what we met before, and as you can see now, is only a branch going to segment 8. So this branch has to be ligated. I usually put an hemlock and then a metallic clip on the part which stays, because I have some hemlock which slept away. So now the transection goes on with the just following the vein. I think this is very important because you have always the right plane, And of course, you need a very good anesthesiologist. You see a very low volemia, and you need a good anesthesiologist. And in this way, you can identify and cut all the branches going to segment 8. And in this way, you are sure you have a good margin on the lesion, which was, as you saw, a big lesion. So the branch of the right hepatic vein can be followed until the Husonian sheath. And you finish the resection just dissecting the branches going to segment 7. At the end, you see the resection line with the vein, which has been exposed, and all the remaining liver, which is healthy and very well vascularized. Thank you.
Thanks, Alessandro. Great presentation. You showed how much is important the combined use of ultrasound and the ultrasonic dissector, which is probably the perfect combination: ultrasound, ultrasonic dissector, and energy device. Then obviously we have many energy devices available. It's fair to say that if we have now the opportunity to be together, we have to be grateful to Olympus, and his energy device is one of the most used. That is the Thunderbit. But as you said, we have many options, and as Osmond said, it's very important that each of us get used to a specific energy device, because that's actually something really individual tool. So thanks.
I totally agree, and I have to say, you mentioned the ultrasound, you mentioned the ultrasonic dissector, and you mentioned the energy device. I think that you need to use ultrasound. It's probably better to use ultrasonic dissector, but you can choose the energy device you have the habit to operate with. So I think really we have very good energy devices, and you have to use the one you have, you feel comfortable.
Okay, thanks a lot, Alessandro. Maybe Osmond, you want to show us a video from your group, your group? Who is the operator? Is it you in person?
So now you will see now one video first, which is Björn's operation, and you will see he is slightly more brave than I am with the energy device. And then afterwards you will see my own operation, which is a little more.
Okay, great.
Yeah. So this is again. This is. Yeah.
Great, thanks. Okay.
This is segment 8 lesion, and as we are focusing on the basics, it's mostly about the transection. Can we start the video, please? Yeah. Okay. I don't have the ultrasound of this one here in the video, but we mark just like this. Alessandro, what you're doing is an art form. When you do these drawings on the liver, it's very beautiful. You see, we are Vikings, so we just make a sketch of what we hack. But we are thinking when we are doing it. We are making this dissection line as I showed you, and Björn is really aggressive with the ligature, just doing the parenchyma. This is probably without Pringle also. And now when we get in the deep, Björn is looking with the aspirator for the pedicle and for the branch of the right portal vein here. So now we are much more careful when we go into the deep, and it's very important to clear the margins on the side to be able to lift the specimen out, so that we can have a good open book when we get to the danger area. And here we are approaching the central structures. You see that we have a little bleeding here, but Björn can see the structure, put the hemolock on, and we have control. And we put 1 or 2 hemolocks on and divide with the energy device. We also agree, Alessandro, that you can absolutely put a double safety is good. So a metal clip, if you have less space, is very good also. So this is the feeding pedicle into this tumor, and when we then go behind and we see that there is also, as we know from the scans, a hepatic vein that we need to dissect off the tumor. You see here we use the ultrasound as partially a crush clamping, just crushing and burning and crushing and burning without cutting, and then the parenchyma will just open up nicely and with good hemostasis. Ultrasound to check on the margin. Again, I apologize not for having, we have a technical problem at the moment. We can't get the ultrasound on the video. We have some Surgicel, as you see here, to save ease the hemostasis. And then we have the specimen completely free. Mark, you were talking about the posterior margin, and we see here that it is possible without making a diamond to just swipe the tumor to resection around, and then you can make also a quite straight margin in the posterior side.
I think it's almost a diamond. No, because you make a straight line around it, not a circle. That's the key.
It's a straight line, yeah. So this is the final. This is the what I call the cannonball resection. It looks like you shot through the liver with the cannon. So this is a very this is the fast operation, less than 2 hours, little blood loss, but this is a very this is an expert operating really and knows how to feel the parenchyma with the liver. This second case is me operating sigmoid cancer, and there is a resection in segment 2. This is what I would describe as a quite good case to start with when you have some experience, because it's a little bit difficult because you need to take, if you want to save the left lateral segment, you need to think a little bit, but it's not very dangerous. Some adhesions. And you see here we can use different energy devices as we talked about. Use a cold scissor close to the adhesions. And you see that in this time I was more lucky than I was on Monday, and I didn't do damage on the small bowel. You can see the tumor. Luca, you said that we cannot palpate the liver, but you can palpate with your instruments a little bit. So you can feel, and here you can see the liver. I see the tumor on the liver. And then we do the marking. Actually, in this case, we didn't do any ultrasound because the resection plan was quite straightforward. And we knew that with the aspirator, we could find the structures. You have to mobilize before you start the resection. And then we do the opening of the parenchyma with just the energy device. And then after a while, when we go deeper in the liver, we switch to the aspirator. And we will see a couple of different ways of dividing the bigger structures. So as we have a very big practice of colorectal cancer metastasis in Oslo, we are less used to doing really anatomic resections, but we do really tumor-focused resections. So we try to resect the tumor-bearing segment of the liver, not the anatomical segments. We often say that we let the tumor decide and not guano segments to decide. And you see here that we need to take the distal part of the segment 3 pedicle. We choose to do a stapler on this one. This is to show different ways of doing it. The maybe the normal way to divide this pedicle would be 2 hemolocks on the central side and 1 on the right side. You see also with the stapler, it's a big instrument and you can do some damage with it. So here I made a small tear in the left hepatic vein, or in a big branch. And we see that this is from the period when we didn't do a lot of Pringle. And I have a hole in the vein. So how to fix this? Well, it's important to remember that you can use your grasper as a vascular clamp. And this resection is not dangerous in any way. So we decided just to put the grasper on to stop the venous bleeding, and then finish the resection, and then afterwards fix the bleeding. So here, to test the instrument, we did the pedicle just with the energy device. Again, a hemolock would be maybe a more normal choice for this pedicle, I would say, also in our practice. So now we have only vein left, I think. And the hepatic vein is always divided with the stapler. And then the bleeding from the hepatic vein further down is controlled with a suture. I think we put a pledget on the end of a barbed suture like the V-lock or the Stratafix, and we find that a very nice way of controlling bleedings like this, or bile leaks. Small ligament is hanging there. You see, I didn't mobilize quite enough. To be sure, and as I was a bit scared, as I had the hole in the vein, I put a Taco-Seal patch on top of the sutures, and luckily there was no problems after the operation for this one. So this is the Viking way of doing it. Thank you so much.
Thanks, Osmond. Thanks. Actually, 2 great videos. You play with the word of Vikings, and because you are searching for compliments, they say. Actually, 2 great videos. I think what is really important is that you showed the concept of dissector that can be done with the ultrasonic dissector, which probably needs less experience, or obviously can be done with the crush clamping technique, which I think needs a lot of experience, like obviously the great experience of Björn. To me, if I may give a suggestion to beginners, probably it's better to have the ultrasonic dissector available, because again, when you have a lot of experience, that maybe you can do something without counting on technology, but probably at the beginning it's important to be prepared with all instruments to make everything a little bit easier. Do you agree, Osmond?
I agree absolutely, and this is what we trained what we say to our fellows, and also when we have international guests here coming to see how we do it. We also always say that you should use the aspirator all the time, because it's easier, and it also, you need to train using it. You need to find out how much pressure you should use it, how is the movement really, and if you don't train with it, you cannot use it when you really need it. So absolutely, but we also wanted to show that you can, with experience, you can also train the crush clamping technique with an energy device.
Thanks a lot, and thanks a lot for showing us also how to deal and to fix a vascular problem, because that's another important issue for the beginners, because obviously bleeding is always something that makes a lot of fear, but you showed us how to manage it. We are running a little bit late, so unfortunately I'll not ask any other comments of these 2 videos, and I want to ask Mark if you have a video for us, so you can show us the Dutch technique.
Yeah, my video basically was basically copy paste of Asmund, so I'm not sure whether we should show it. The one thing that I was going to show is very simple technique.
Sure.
I can just tell it to you. Is we cut 5 centimeter of a measurement tape, right? Like the one you get with your sterile pen, and we put it actually in the abdomen to measure the depth of the diamond shape.
Okay.
Because we do the diamond shape straight lines, and you can actually measure. So the first time you need to tell your nurse, because she will get a heart attack. But once they know, it's a very simple trick to be objective, because I know many surgeons that put in a clamp and measure the length of a clamp. But if you put in a clamp in the depth of a metastacectomy, you go in 45 degrees and it's never a correct measurement. So 5 centimeter of a measurement tape to measure the depth of the metastacectomy is a very simple trick that I was going to show with a video, but it's more easy to tell it now to you like this in 20 seconds.
Okay. Okay.
Mark,
please,
Mark,
Osman.
don't you think that if you have the open clamp, we use the open clamp, we know that there is 2.5 centimeters from here to here, and straight in that should be quite something of the same. But I never thought about using the measure.
Yeah, that's the Viking way, of course. But then if the lesion is 3 centimeters, you want to go down 4. And of course, we always say, I think it's enough. But with the measurement, it's like objectified. But it's just a small trick. And I saw it once from a Vietnamese surgeon who taught us to do a bile duct reconstruction in a child laparoscopically. And he was measuring with the tape. And I thought, hey, that's a simple trick for laparoscopic liver surgery as well.
I will bring it back home.
Okay. So, thank you very much. What can I say? I'm sure people who has been connected appreciate this round table. We had the possibility to show how to start to do easy cases, even if your videos are already addressing pretty important cases, to see I would say, the Southern Europe technique, the Middle Europe technique, and the Northern technique. But I think at the end of everything, all technical tips are almost the same, and at the end of everything, what I think should be the final message is that there are important steps to be done, and everything should be really prepared, and ultrasound has to be absolutely clear to all surgeons, how to set up the cases, how to train people, how to perform resections. So I cannot say anything more. I'm really grateful to you to have been with us, and I'm sure everybody has been happy, and you know that this roundtable will be on Met channel in the future, so that any surgeon starting laparoscopic resection can blame on you for any mistake. So thanks a lot, and I hope to see you soon in the next future.
Thank you.
Bye bye.
Bye,
Bye, Alessandro.
Bye,
bye
bye.
Mark. Bye, Osmond.
Thank you.
Bye bye.
Bye-bye.